Good morning, everyone. In this short video, we will present our arthroscopic assisted technique for acute distal biceps tendon ruptures. A longitudinal skin incision is made centered on the radial head. In the subcutaneous tissue, the cephalic vein and the lateral antebrachial cutaneous nerve are identified and gently retracted laterally. The retracted tendon is then identified proximally. In highly retracted tendons, the skin incision can be enlarged proximally in an italic S fashion. The distal tendon sheath is then identified and opened with the use of retractors. With our technique, there is no need for an aggressive retractors usage. The scope and radiofrequency are then inserted in the tendon sheath. Scar tissue is removed to expose the bicipital tuberosity bone as clearly as possible. Bicipital tuberosity is then prepared and drilled. A 5 mm transparent cannula can be used as a soft tissue protector. In order to be perpendicular to the tuberosity, the forearm needs to be maintained in maximum supination. Tubicortical drills are performed with 3 mm key wires. Two 2.8 mm old suture anchors are placed and stability is checked. 2 suture anchors are used for this technique. The tendon is now prepared. The proximal anchor is used to fix the lateral component of the tendon, whereas the distal one is used for the medial component in order to restore anatomy as close as possible to the original. One suture of the proximal anchor is passed through the tendon in a crack-off fashion for 4 to 6 cm proximally, while the second one is used for a mattress suture in the distal end of the tendon. The same process is done for the distal anchor. Distal ends of the crack-off sutures are pulled to bring the tendon close to the tuberosity, and under the scope evaluation, the tendon positioning is checked. Mattress suture knots are then tightened using an arthroscopic knot pusher. The crack-off sutures are in the end tightened. Stability of the tendon is checked in both pronation, supination, flexion, and extension movements.